I think this is great. We can get started. Thanks everyone for joining this cafe, which we usually host the last Wednesday of every month. And our goal is to bring together our partners from nonprofits, companies, and researchers to collaborate and share knowledge around specific topics like optimization, machine learning, etc. It's actually a great pleasure today to host Victor, with whom actually I have had the pleasure to work during the COVID-19 pandemic in Nepal, where we used optimization to help optimize the location of COVID-19 test laboratories in Nepal. And having had the pleasure to work with Victor and know his expertise on the field, it's a huge pleasure for us to host him at this session today. Over to you, Victor. Please introduce yourself and talk a bit about your organization, and then you can start with your session. Thanks.
Thank you, Parvati. Can you please show my presentation, the first slide, and we can start moving from there. Lovely. That's the one. Yeah. Well, good afternoon, good morning, good evening, colleagues. And thank you, Parvati and Analytics for a Better World for inviting me to the cafe. It is a great pleasure to be here. And because it's a cafe, I'm going to have the most relaxed approach to it, and I hope you indulge me in such approach and behavior. So today I'm going to talk about the optimization in the public health arena, and I will provide some experiences from the field. Let me start. Before doing so, let me just give a couple of disclaimers. The first one is, as already Parvati intimated, my expertise is in epidemiology. These days, I'm not sure I can call any or can claim any expertise at all, but that's what I've been doing lately. And I'll talk a bit more about my agency, my current employer, in a moment. But the disclaimer is that I'm not expert in optimization by any means or stretch of imagination. I've been fortunate enough to engage with people like Parvati, but also Dick and Joaquin or Joaquim. I assume they are on call as well. And that actually leads me to say that if you have any particular questions on the optimization methods that I will be introducing today, on the methodologies, I will refer you to engage directly with them, because they are the experts on the methodologies. I am not. I don't think on that line, I don't think I've got any equations or formulae in my presentation. And if I talk about concepts like stochastic optimization or something along those lines, it will be just by accident. So I think we will have a Q&A session at the end. I will try my best to keep to those 45 minutes, Parvati, that you gave me for the presentation. But the other disclaimer or warning is that I haven't timed myself, so perhaps I have far too many slides, but we'll see how it goes, and we'll stop if needed to allow time for Q&A. So if we can move to the next slide, Parvati, please. Right, so some of the experiences today will relate to my current, some of my experiences today will relate to my current employer, which is the UK Health Security Agency, is an executive agency of the UK's Department for Health and Social Care. It's a medium-sized organization, over 5,000 staff, doing all the public health and health security issues in country. Within this organization, there is a section or program on global operations, and within that program, it is my unit, which is the public health rapid support unit. And our role is about 60 people in this unit, is to be deployed to assist countries that are facing outbreaks of infectious diseases anywhere in the world at very short notice. We also have a mandate for research and capacity strengthening. And as I said before, some of the examples today will refer to my experiences with my current employer. But there are also examples, as Parvati was alluding to, with previous employers like WHO in Southeast Asia. But I'll talk about that in more detail later on. Parvati, we can move to the next slide, please. Well, yeah, if you can show just the disclaimer just for a second, so people realize that all the opinions are mine, and surely they don't reflect, the opinions of all the policies of my current employer or previous ones. The next slide, please. And this is an outline of the presentation. I will cover a bit on the optimization landscape in healthcare and public health. I will describe the Nepal experience that Parvati was alluding to. And then hopefully I will have time to cover the other topics, which are a brief explanation about work we did with rabies, and then a couple of challenges, or one challenge that I'm facing now that I like to share with colleagues on call. And I love to hear ideas about how we can tackle or address this challenge. And hopefully we'll have some time towards the end to describe another challenge that we are facing, or some perspectives for collaboration with Dick and Joachim and Parvati around the situation in Sudan. And next slide, please, Parvati. Yeah. So, as I said before, I'm not expert in optimization, but I know, and I'm sure there might be colleagues on call, that optimization has been used quite extensively. It's a well-established discipline in in healthcare. But and it's mostly used in matters of scheduling, whether it's workforce or surgical interventions and others, or for example, the deployment of ambulances and other commodities in healthcare. But I don't believe optimization has been used so widely in public health, and perhaps it's because the setting in which public health emergencies happen is a bit more messy, and as a result of that, measuring the impact of the outcomes, it is difficult to tease out the real impact of an intervention, given all the confounding factors in such an emergency situation. Next slide, please, Parvati. So these are, but of course, there have been applications of optimization in public health. This is just one slide showing some of such examples. Fend and our colleagues basically conducted a Delphi study to come up with definition of optimization in public health, and they identify a number of criteria they thought they were important for the application of these optimization. But you can read the points there. Basically, that there is a need to inform the effectiveness of intervention, and those methodologies can actually lead to improvements. The other 2 points that I highlighted in red, the quality of the data, that there are stable and ongoing resources to support it. The reason why I highlighted in red is because, as you can imagine, in public health emergencies, outbreaks of infectious diseases, these 2 criteria are not that easy to deliver, and those are the challenges that we face on a daily basis in such situations. Yeah, I mean, Wolfenden basically identified that optimization can be used mostly either to optimize or improve the effectiveness or efficacy of interventions, but also to optimize the implementation of interventions. And along similar lines, McCrabb came out with similar definitions, but he suggested 2 frameworks, which I pasted on the right side of the slide. To the similar effect as Wolfenden. One is what steps to follow in order to optimize interventions and the efficacy of them, or the effectiveness, and the other one is to optimize the implementation. And the latter one apparently was claimed by the authors. It's got some resemblance with quality improvement cycles by Deming and other quality colleagues in the past. And I think I've got a quote by Deming later on. Next, please. Of course, so I already mentioned that we had some examples in the public health arena of optimization. We couldn't ignore, of course, the largest public health event in the last 100 years, and that is, of course, COVID. And there were quite a significant number of applications during COVID. Here is just a very short list of them, mostly looking at ways of optimize the delivery of goods and commodities such as ventilators, oxygen, and other commodities, PPE to hospitals and other healthcare facilities. Next slide, please. Now, I mean, I think most of the examples in the previous slide actually were quite sophisticated examples of optimization. Probably at the very end of this scale, or or this trend line in terms of difficulty. They were looking at prescriptive analytics or as such, but and that is perhaps because COVID obviously was a protracted emergency. We had a couple of years or longer to develop the models, to gather the data in sufficient amount and quality to support such complicated and sophisticated approaches to optimization. But in many other situations or public health emergencies that I face in my job, they're acute, they're short-term, and such standards of data quality and quantity are not there. So a lot of the time we just stop at the very bottom of this scale, and we look at descriptive analytics and statistics. Sometimes we manage to go into the diagnostic ones, and then moving into the predictive. Some of the examples I'll be covering today, of course, they travel along this line. We do descriptive and mapping out of processes and things like that. We got some examples about predictive analytics, looking at what if different scenarios and things like that. But let me just say, and that is the reason why I got this picture of Homer and its peculiar distribution of thoughts in his brain. I can see myself in that picture because unfortunately for public health practitioners, the uses and availability of the optimization techniques is not widespread, and the knowledge is not there, and there is a lack of awareness about how can we use optimization techniques, and even to know what sort of questions optimization can answer, which is also similar. One could say similar, similar statement, or produce similar statement for mathematical modeling to explain the dynamics of disease and the impact of different interventions. So a lot of education and awareness is needed in order to improve the rollout of these techniques in public health emergencies. If we can move to the next slide, please. Oh, this is also somehow related to the previous slide. I came across this algorithm for the application or for the selection of different techniques to inform decisions only last week attending a conference. I really like it, although it's mostly based on technical attributes. But as I said, similar, we in public health emergencies, we tend to stop at the very top of this algorithm. Occasionally we got into this stochastic programming at the very end. But I'm not particularly bothered about the concentration of efforts on at the top of this algorithm, or at the beginning of the trend line, the previous slide, because I believe that actually putting together a robust description of the event is already a great achievement, especially in those situations. And I think also aligns a lot with the fact that descriptive statistics has got a great power, and even in areas so well developed like in finance and portfolios, most of the applications are quite simple and using heuristics in 80 or 90% of the cases in portfolio management. If we can move to the next slide, please. Right, let's move on to the examples, and let's start with the examples. So this is the first one, and this is an example. This is the epi curve of COVID-19 in Nepal during can read from here 2020 to 2021, and there are two lines, as you can read there. One is the number of cases in blue, and the other one is the number of tests, PCR tests conducted in country. And the reason why I'm showing you is just to give you an idea of the background of COVID-19 in the earliest stages in the country, that it was the target of our joint investigation about Nepal COVID-19 testing optimization. So if we can move to the next slide, Prabhati. So again, on the background, I was with WHO Southeast Asia regional office when COVID started, based in Delhi in India. The regional office covers the entire Southeast Asia region, 11 countries, and Nepal is one of those countries. And towards the end of 2020, back in November 2020, somehow I can't remember now, I got my hands onto a report produced by WHO country office colleagues and also the Ministry of Health and Population of Nepal. That report was a very extensive report and very rich with a lot of data on capacities. And what I meant by capacities or response pillars is the different interventions that we put forward in order to control a disease, in this case, COVID-19. You can think of surveillance, you can think of laboratory, you can think of vaccinations and the likes. And that report was very rich for the laboratory capacity or the laboratory response pillar. So it had tables and tables of data for each of the can't remember the number now, 75 or around 75 laboratories that were operating at that time in November 2020, with information on the number of people, the number of staff employed by laboratory, the backgrounds, whether they were scientific, technical, janitorial capacities. They had information on the number of machines running the PCR testing, and the capacity, the daily capacity, and so very rich information for each of the laboratories. And when I saw that, I immediately, I thought about, well, this is a nice input data that we could match with output data for each of these production units, i.e. laboratories, and the production data or the output data would be the number of samples processed by each of the labs. And we did so. And one of the first analyses that we conducted, which I'm not presented here today because it's still work in progress, was in fact a sort of benchmarking approach, data envelopment analysis, looking at finding the ways of improving the performance of every lab relative to the others. But what I'm presenting here today is the other three analyses that we conducted. And they are described in this picture. So we start, in fact, with a within lab analysis, or an analysis of the within lab processes. And then we move on to an analysis of the network of labs in country. As Parvati alluded before, we're looking at what might be the optimal location of those labs in country to provide a better service, and also with some considerations about inequality. And the final one, which I defined or labeled as coordination, we were looking at how we improve the transfer of samples among the labs in order to provide, again, the best service to the population. Couple of things here around the organization of this effort. Each of these pieces was conducted by different groups. I was very fortunate. I engaged probably in early 2021 with IFORS, the International Federation for Operational Research Societies, and I expressed and shared my ideas, and they put me in contact with these three groups: the Polytechnique in Montreal, colleagues at this institution. They run the within laboratory analysis with Parvati and colleagues from the University of Amsterdam and Analytics for a Better World, who conducted the network analysis, and then colleagues from the Karlsruhe Technical Institute, Hannah, and others who all conducted the coordination analysis. And that is what I'll be describing in the next few minutes. Next slide, please, Parvati. Right. So the first one was the analysis of the processes within the lab. And these are the questions that we wanted to test. How do laboratories compare to each other? How do they compare with an international benchmark? It was a state-of-the-art laboratory in the States. How do we identify and eliminate or reduce bottlenecks in the laboratories? And then we study a number of scenarios or what-if scenarios. Yeah. Next slide, please, Parvati. Nothing out of the ordinary here. That was the approach we followed as a standard methodology. Perhaps the only thing I can say at this point is there was a lot of consultation with the stakeholders back in Nepal. Because of COVID, we hosted or held a number of virtual conversations with them, colleagues from the National Public Health Lab in Nepal, but also colleagues with a laboratory background at the country and WHO country office to populate the model, which I hope I can share in the next slide, Parvati. Yes, that is. So So that was the output of the engagement with colleagues in Nepal to describe an average lab in Nepal conducting PCR testing for COVID-19 during the pandemic. Well, you can see basically the different steps in the process, from the reception of the samples up to the production of results that described over there, and then and occasionally, of course, there are some results that they are not conclusive enough, and they go back into the process with some feedback loops and the likes. And it might look simple actually, but it turned out that such map, as we are showing here, was quite new to the colleagues in Nepal, and such exercise wasn't conducted up to that point. Next slide, please, Pramati. Of course, we use that map to model the approaches. I think. Yeah. Oh, sorry. I failed to say actually in the previous slide. The model. I mean, it wasn't the slide. The methodology was a discrete event simulation, and we started with this scenario where we basically had a modality of arrivals or samples. I don't want to get into much detail. And 20% of the samples came from in some of these testing facilities. There were like 75 at that time. Some of them, they were also hospitals, or embedded in hospitals. So there were samples coming from the patients in the hospital. That is 20% internal, but they were also receiving samples from other testing facilities around, and that is the 80% scenario here in the sample arrival. As I mentioned before, 5% of inconclusive test rate, that they had to be reprocessed. And here you have the different distributional assumptions for the processing times across the entire process in all the steps that I mentioned before: the identification, registration of samples, the exporting the data about the results, and so on and so forth, and the parameterization of those distributions. As I said, this is the standard mapping and the standard capacities of an average lab in Nepal. And we were also looking at the equipment and the number of staff with the detail of the background and the roles they were performing in the lab. If we can move to the next slide, please, Prabhat. Yes. As I said before, we populated the model with all these different inputs. So the samples arrival per day, by day. There was also variability in how the samples arrived within the day. We also modeled that. Is the second column in that picture with different shapes, and the tables on the left, on the right side of the slide. I cannot read them, but basically they describe the different distribution of staff across the different steps that we saw in that map, and also that distribution of staff by background. So we had scientific colleagues, technical colleagues, and things like that in a shift of 8 hours, and how they moved around. And we use all this information as input into that discrete event simulation model. If we can move to the next one, please, Pramati. And of course, the whole purpose, as we said at the beginning, was the identification of bottlenecks out of all the processes in that table on the left of the slide. 1, 2, 3, 4, 5, 6, 7, 8, 11 processes in that table. 2 of them in red, the identification of the samples and the registration of the samples, came up as the bottlenecks, because we utilized 100% of all the resources at that point in terms of people, and they were creating a backlog of samples in the entire processes. If we can move to the next slide, Pramati, please. Yeah, we can also identify, or we could come up with a rank order of the different steps that the demanded major human resources, and those are listed there. The identification of the samples as they arrive, the uncapping, a lot of manual stuff here, transferring the samples, RNA extraction and exporting. So we could identify how many, what the headcount that it was required to feed these processes in the lab. Next slide, please, Pramati. And of course, the beauty of all this is that once we simulate the system, we can start playing with what if scenarios, and And we played, in fact, with quite a few. I'm only showing here a token of that. But we tested whether what was the impact of having more like an automatic the contrast between manual extraction of RNA versus automatic one. That is the plot on the left side of the slides. There was no much impact until we moved from 75% of manual extraction, where we saw a drop in the number of samples that we could handle daily. We could also see, we simulated the impact of stockouts or of reagents as we had during the pandemic. We had periods where the reagents to feed the automatic extraction of RNA were not available. And you can see here on the northeast of the slide, the average turnaround time increased from an average of 48 hours up to 100 if there were delays of 2, 3, or 4 or 5 days. And on the southeast corner of the slide, again, we were looking at the impact of different staff scheduling into the across the system and across the different steps. I cannot remember what schedule 1 to 4 meant, but the thing here is just to show that we were able to actually come up with or identify some non-linear behaviors that otherwise we would have not anticipated. So it was a good experience, an eye-opening exercise for policymakers. If we can move to the next slide, please. Yeah, so up to now, or up to the previous slide, that was a quick summary of this analysis by colleagues at the Polytechnic. We are now moving into the second piece of work, and this is the one that Parvati and Joachim and others at the University of Amsterdam and Analytics for a Better World did for us, and it's a description of the network. So as I said before, we're now looking at a period actually between May 2021 and November 2021. The data was most robust in that period, and that's why we focused in that time. Here are a few reflections, a few insights about the network at that time. 89 labs across the 7 provinces in Nepal. That is the table on the top right, top left. And as you can see, is that there is a lot of heterogeneity in terms of the coverage of the population by province. I'm struggling with this coordinate thing, and so on the southwest of the slide is the number of COVID labs and how there was that progression in opening up new labs from May to November 2021 by province. In that period of those months, actually, we had 20 new labs operating in the country. The map on the top right basically provides an idea of the geographical location of those labs, 89 labs. I don't know if you can see it, but there are some green areas associated to each of those pins, and those green areas basically identify the coverage of those labs or how much population is within reach of those labs, within 60 minutes of driving. And of course, it's very clear that we're not covering a great extension of the country. And we set up a number of thresholds. That is what we're trying to show on the southeast corner of the slide, the last plot here. So we use these 4 criteria where we're interested in knowing the coverage of the population or the number of households within these 4 thresholds. I 30 or 60 minutes walking and 30 and 60 minutes driving. And I hope you can read. So in May 2021, if we look at the 60 minutes driving, 55% of the households had access to at least 1 lab. As we open new 20 labs up to November 2021, that coverage increased to 61%. As I said, at least 61% of the households in Nepal had at least one lab within 60 minutes of driving. Yes, next slide, please, Prabhat. Right, so what we did as well was we collapsed the number of labs. So we didn't study, as I said before, by province, but we also look at other administrative units or levels. In this case, the map shows the number of districts and across the different 4 thresholds, walking and driving, 30 and 60 minutes. The districts in red are basically those with no access whatsoever, according to those thresholds. And so, for example, for the 60 minutes driving, about 26 districts out of 77, I believe, had no access to a lab within 60 minutes of distance or driving. And on the right, as I said, I alluded before to these. We were also interested in, of course, the interest was, to identify that coverage or accessibility to the labs. But we suspected there might be also issues with equality, and there might be a positive relationship between, high income, or in this case, relative wealth index, and accessibility. And that's what basically we are showing in those scatter plots on the right of the slide. So on the horizontal axis for each of those thresholds or criteria, we are looking at the relative wealth index, and on the vertical axis is the coverage of households, and those dots are basically the districts, and then you have the trend line, which is obviously quite positive, indicating that there was a clear relationship between wealthy districts and having more coverage, indicating perhaps the presence of some inequality. So districts or poorer districts having lower accessibility to the labs, the ones obviously on the bottom corner of those scatter plots. If we can move to the next one, Prabhati. And of course, the optimization. So up to now, it was a description of the network, but we conducted, Joaquin and Prabhati and others conducted an optimization exercise with the aim of looking at how could we improve the coverage of the population by allocating or reallocating the 20 new labs that opened between May to November, according to the results of an optimization model. And that is what I'm trying to describe on that plot at the top of the slide. So if you remember before, for the 60 minutes driving, up to 61% of the population were covered. If we were allowed to place those 20 new labs in the location suggested by the model, we could actually increase that coverage to almost 72%. And we could, of course, locate those or identify the geographic locations of those new 20 labs as optimized by the model. And those are represented by those pink pins on the map. And in fact, 17 of these 20 labs that opened from May to November, the model suggested to different locations than the actual ones, and only 3 occasions or 3 labs there was a match between the results of the optimization model and the actual labs opened by the local authorities. In summary, there was a very low accessibility in most areas, and I'm sorry, I should have actually don't know how familiar you are with the geography of Nepal, but so Kathmandu, exactly. Yeah, thank you. Someone is, I assume, is you, Parvati. So Bagmati, that province with a greater concentration of labs, is where the capital Kathmandu is, and the coverage over there, of course, was relatively good, but not so in other hilly areas in Nepal. As I said, very challenging terrain. And accessibility was quite low. As part of the optimization results, we also look at, how could we use the pool of 1,600 healthcare facilities in country to create, where we could locate all the labs, or how many labs we could open across or from that 1600 pool in order to achieve the best coverage. And the results show that with 375 of them, we could reach a threshold of 80, almost 81%. We could see that overall there was no, when we maximize for the quality, in this case using the relative wealth index, the overall coverage didn't change, but coverage got better for the districts with the lowest relative wealth index. Let's move on to the next slide, please, Parvati. Right, and this concludes the second piece of analysis, as I said, conducted by Analytics for a Better World. The third one was that coordination conducted by Hannah and the Karlsruhe Technical Institute. Here I basically just providing the motivation and the questions that we were looking at. As I said before, is there any way of improving the entire network by suggesting or facilitating coordination mechanisms to support the transfer of samples between labs with an excess demand and others with some spare capacity? Next slide, please, Parvati. 38 already. Yeah, so I don't think I'll have time to go in great detail through these. That is the simulation procedure. I invite you to read the paper by Hannah published last year where she describes the entire methodology. We basically had a day as the as the time that we were playing with, and yeah, we were looking at, as I said, towards the end of the day, how many samples were required to be moved from the labs facing an excess demand to others in the vicinity. Yeah, next slide, please, Parvati. Yeah, we started, of course, mapping the demand and the capacity across the provinces, and this shows the capacity we had in the 7 provinces in the country. As you can see, there was plenty of capacity to absorb the number of samples, apart from Lumbini, Madhesh, and Karnali. No, sorry, Lumbini, Gandaki, and Karnali. Those 3 provinces where there are some spikes of demand that we could not address properly at the beginning of the outbreak or that period. But in the others, there was plenty of capacity, and most of the mass of the picture is below the line of 0, indicating, as I said, that we got plenty of capacity. Of course, this only shows the detail at the province level, and it doesn't capture the heterogeneity within the provinces, among districts and among labs. So there was, of course, some labs that they were facing a lot of demand, and others that they have some capacity, and that justify the coordination and exploration. Next slide, please, Parvati. Yeah, so these are the results of running the models. Our outcome basically was to quantify the fraction of delayed samples. I think we were looking, don't quote me on that now, I think we were looking at samples that could be processed within 24 hours. So basically what the table says is we got if no coordination, or the actual situation was that about 21.4% of the samples, that is the second column, the last figure at the bottom, 21.4% of the samples had some form of delay if there was no coordination. The moment that we brought some level of coordination, that is the second and the third and the fourth column, we dramatically reduced. One could dramatically reduce the fraction of delay samples to 4.1% or 2.3%, and that. Okay, I should have said that before. The samples could only be processed within the provinces where people, someone submitted samples was leaving. There was no ability to submit samples across different provinces, so that was one of the constraints or restrictions. So respecting the restriction, those are the numbers that we found, 4.1 and 2.3. You can also see the detail between government-owned and private labs, and there were, of course, some heterogeneity across the provinces. But if there was no restrictions and we could move samples between labs, regardless of what province they sat, and there was no, the fraction of delay samples was 0, and those are the last 2 columns. Let's move on, Prabhati, please. Next slide. Yeah, so that indicated that if we had a a central authority looking at the coordination of the samples, we could improve and reduce that fraction of delays. Of course, there are some costs associated to that, cost in terms of moving samples from A to B, and the cost of coordination. We look at ways of minimizing those costs. Some of the tables here show some of those results. For example, that table at the top basically says or tells us the fraction or the proportion of samples that needed to be moved across labs in daily, I believe, about 3.3%, and a total of almost 500 samples. And the beauty of these, because these model fed from the models from Porbathy, is that we could locate exactly the best labs, in the vicinity of those labs facing demand, and that is what I tried to represent with that table at the bottom. So we could say that from lab A, the best way of reducing the excess demand is moving this amount of samples to a very precise lab in the vicinity. Let's move on to the next slide, please, Prabhati. Yes, I don't think I have time to cover these. We conducted a number of experiments. Once we developed the model, of course, we could play with different scenarios. Although this was a quite comprehensive approach to the assessment of the laboratory and its network for Nepal during COVID-19, I don't think we can claim that it was a systems approach, because we took the lab as an isolated system. And ideally, one should have represented this as part of as a wider or a system of systems where, of course, the labs, they have impacts or from the procurement and supply chain management, from the submission of samples and the sensitivity of surveillance sources and the likes. But that might be, an effort for some other time. The next slide, please. And I'm sorry, I'm now going through quite quickly through the slides, but I've been told that we need to leave at least 10 minutes, so I'll try to finish in 5 minutes. And so the next slide, basically, as I said before, this is another experience that, so the previous example was when, whilst I was working in WHO. This is an example of work that I conducted when I was working in PAHO, the Pan American Health Organization, in this case, the regional office for the Americas of WHO. And we were interested in looking at how can we optimize the portfolio of different capacities to control and eliminate, in this case, rabies. So similar to the response pillars that I mentioned before, so for a disease control program, you have a number of capacities. For rabies, of importance are, the presence of post-exposure prophylaxis if you get bitten by a dog, vaccination of dogs, surveillance, and so on and so forth. And so we identify with a group of experts, the comprehensive list of capacities and subcapacities to inform such program. And the plots, the scattered plots and the line plots on the right, basically, we conducted depict the results of a multi-criteria decision analysis conducted with a bunch of such experts, where these are basically the value functions of some of these capacities across a number of scenarios. I don't have time to cover these things, but suffice to say that we were looking at different scenarios of risk with the presence of disease, or with its absence. But we're also looking at, different budgetary situations where we may have, plenty of money, so we can invest, i.e. a scenario of gains, and versus a budget cuts where we had to reduce investment in some of those capacities, i.e. in a scenario of losses. Let's move on, Parvati, to the next slide. Because what basically we conducted that exercise to trying to define that value and creating a value that was consistent and compatible across that long list of capacities in order to inform portfolio optimization. And this is what we conducted. As I said, it's the simplest form of portfolio optimization, in a way that, once we can allocate a value to each of these capacities, we ranked all these capacities. We were allocated money across that ranked list of capacities until we ran out of money, but we could play with different combinations of that portfolio depending on different considerations of political reasons or whatever. And we were able to compare, of course, across different portfolios using value for money. As a simple application of portfolio optimization, of course, not looking at any dependencies between the assets in this case, but one that it was interesting. If we can move now to the next slide, please, Parvati. Yeah, let me just, and the next one. So Yeah, let me just cover this one very quickly. So this table here is, so up to now is exercises or pieces of work we've conducted. This now is something that has been bothering me for a while, and I'm not entirely sure how I could tackle this. So I'd love perhaps to hear some suggestions in the Q&A session after this. And I call it the Strategic Surveillance Challenge. This table actually is a real one. I don't know if you can read, but on the rows, what you have is a number of surveillance sources that emanated or stemmed from the COVID-19. And towards the end of COVID-19, there were some discussions about how can we use these surveillance sources for other purposes and other diseases. And the purposes are listed as columns in this table. So we wanted to, and we wanted to identify what was that combination of surveillance sources that could deliver against all those objectives. And the objective that is written in that blue box at in the middle, and I quote, I took this, from that piece of work, is to determine how current sentinel and non-sentinel surveillance systems would best synergize to address these questions in a sustainable manner. For me, synergize reads a lot like a portfolio approach, and in a sustainable manner means looking ahead and of course bringing all the uncertainty around that. Unfortunately, that wasn't the approach followed at the time. What it was done basically was to put together around the table a number of experts, and they were asked to allocate crosses from 1 to 5 to each of these cells in order to identify, as I said before, what might be the best combination of these surveillance sources to hit all those objectives as columns. Next slide, please, Parvati. At no point in time we question things like, which stream or surveillance stream delivers the greatest value for money, how quickly we need to combine these different surveillance sources, where we start developing or deploying these surveillance sources because there was some heterogeneity at the spatial level, and there might be some spatial borrowing of capacities, how sustainably, when it reaches its peak and requires new investment, and of course, considerations about tipping points, and there was no consideration whatsoever about correlations between the different units. So, as I said before, if we can move to the next slide, Pravati, perhaps. Yeah, as I said, it seems to me we're looking at an optimization of projects. And we could start very simply just by looking at, not at those objectives in that very complex and non-table, but perhaps more relevant things like the sensitivity or the timeliness of the surveillance, bringing also uncertainty, as I try to depict in the table below. But yeah, so this is the sort of challenge that I'm trying to figure out, and I'd love to hear ideas later on. And if we can move to the next slide. Yes, I think I'm going to skip this. This is basically a representation of a surveillance system. I just want to give you a flavor of, so the previous one, it was a strategic decision in terms of investment, a portfolio of surveillance sources. This one basically tries to show another challenge that we are facing right now. It shows the system or a map of the different processes feeding a surveillance approach in a country in Africa, responding to an outbreak. It might seem not a huge achievement, but just putting together all these steps and arcs and nodes was a great exercise. Now we will try to populate these and see if we can, come up with different identification of bottlenecks and the likes. Next slide, please, Parvati. And next slide. Yeah. So let me just finish 1 minute and I'll finish. So far, I've been, we had plenty of examples of how conducted optimization exercises in protracted emergencies. COVID is one of them. Rabies is an endemic condition, has been around for centuries, if not millennia. And the strategic challenge that I'm facing with surveillance, again, is something that it's not entirely urgent that we have to do. But unfortunately, there are situations where we face huge emergency and the time is a priority or is of essence and we don't have it. And one of those situations perhaps is Sudan. I don't think I need to remind the colleagues on call about the dire situation of Sudan with a civil war as we speak. But if we can move to the next slide, Prabhati, and the next one. Yeah, and the next one. This is the last piece of work that we're trying to implement with DIG from analytics for a better world and the University of Amsterdam with other colleagues as well, where we're trying to basically apply a similar study to the one we conducted in Nepal but not just restricted to testing facilities in Nepal, but the different structures that feed into the surveillance of cholera in Nepal, sorry, in Sudan. An outbreak that is still ongoing. So this is work in progress. Hopefully we can progress in the future. And I think if we move to the next slide, that might be the last one. Yes, I think I'll conclude here. I said before that I was going to refer to them in again. And so this is my final slide. This reflects quite neatly how I feel sometimes when I'm operating in those outbreaks. There are better solutions to my problems, but it gets so busy that you don't see them even if they're staring at you, in the face. I'll stop there, Prabhathi. I'm sorry it took a bit longer than expected. Over.
Thank you so much, Victor. It has been really amazing listening to you and see all the different experiments you have done, but also you gave us some perspective on what are the challenges you are seeing and opportunities, which was, I think, very useful. We will take questions now, and I already see questions in the chat. So I would like to summarize those two questions. I was quickly taking a look. You mentioned that there are challenges in applying optimization, and we believe that there are a lot of research work around this, and there are some really good models out there. But what exactly, in your expertise, in your experience, is that the gap between bringing that to something like what you see on the ground, and what are the major bottlenecks and challenges in applying it directly to a situation where there is a pandemic or cholera response? So what are the main challenges there?
Yeah, I think think of Homer as perhaps that brain of Homer is one of the main challenges. There is no awareness of the benefits of running operational research or optimization in those situations. So what sort of questions such approaches can answer? And if you don't have awareness among public health practitioners about this, it's difficult, to engage with that. And also think about, and that's what I like of pictures. You would always remember these things. Think about those guys pulling the cart in the middle of an outbreak. You are completely busy doing, and you don't have much time about thinking about improvements. And I've been in that situation, and I missed very clear opportunities because I was so into the to response mode. And you have to create the opportunities to have people from outside that response, to bring you new ideas. We did so actually with Sudan. I was leading the response to cholera in Sudan, and we were struggling with some very basic things. And the solutions that we came about with, they were quite narrow-minded, if I may say, and that we created opportunities to have feedback from colleagues outside, and they come up with natural solutions that we couldn't think of. But when they proposed, and you're thinking, of course. So the problem is lack of bandwidth to think about, beyond that response mode. And of course, as I said before in another slide, in public health emergencies, the data might not be good. The data might not be, supportive enough of very complicated stuff. But even if we can come up with a map of the processes, that is a huge achievement in itself as well.
So I think, to summarize, awareness is one part, but also data is another. And we see a lot of researchers here, and if you have any specific ask, so you already put down your challenges in Sudan, right? But do you think as researchers, we need to also, in our research methodology, understand the context of what is happening, like the gap between the domain expertise and, let's say, what optimization is able to do?
Oh, absolutely. I mean, otherwise, it will get completely lost in translation. So I on purpose, I didn't bring any equations. I'm familiar with these things, but if you start putting me equations in a set of slides, I probably jump out the window. And I'm the closest you might get, in terms of awareness about the benefits of operational research for many of my colleagues out there. There is a massive barrier in terms of understanding and the jargon and the things like that the colleagues researchers might bring to the problem. So I think, as I said before, education, having awareness among the public health practitioners about the power of these solutions, I think is important. If you remember, Parvati, we conducted an operational research school when we were in Seattle, with that specifically with that objective, increasing the awareness of public health practitioners to optimization and operational research. And I think that those efforts, they need to be taken into the future as well.
Thank you, Victor. I think we have time for one more question. So anyone in the audience, feel free to unmute and ask any question you have to Victor. Yeah, Hannah?
Yeah, I have a question. Hi, Victor. What do you think besides like larger efforts? You cannot hear me.
Oh, where are you? Oh, I can see you now.
But can you hear me?
Yeah.
Okay. Now, what do you think are outlets to reach public health practitioners besides like larger efforts in the school? What are outlets? Are there blogs? Are there, I would think academic journals not, but other outlets that might reach a larger audience? Can you think of anything?
That's a good question. And I'm afraid I don't have a very good solution. As you said, the operational research journals, they don't reach public health practitioners at all. That is a complete alien field to them. And I'm afraid as well the way they are exposed, of course you cater, when you publish in your operational research journals, you're catering for that audience, that they know the jargon and all the the insights of these things. That is completely impossible to translate for public health practitioners. We try with those schools. WHO, as you remember, they have, and it's been running for quite a few years, they have these program, or they call it SORTED, which is a structured operational research training, and they've been reaching out to multiple health practitioners, public health practitioners out there for the last many years, bringing that level of awareness about public health, about operational research. And one of the reasons, and I'm convinced of this, why we were successful with the 3 experiments we ran in Nepal is because Nepal had such a training a couple of years before. So they were exposed to this training on operational research. It was a very basic level, but at least, the term wasn't alien to them when we went over there and told them, we think we can apply this operational research and optimization to all this data. They were open to that suggestion because they were exposed to it before. But I'm afraid I don't have a clear, idea or suggestion about how can we have a mass approach, to optimize, to introduce optimization techniques in public health. I see more like a process, and work in progress.
Yeah, thank you.
And congratulations.
Yeah. Congrats, Hannah, on your PhD.
Thank you.
Do we have any more questions?
Yes. So maybe I have a question. So for pandemics and so on, it might be good also to have already prepared methods and methodologies such that we can apply it very fast, because now it's maybe too late. Do you see value there?
Absolutely, Dick. That is a great suggestion. So what we're trying to do, but it's another level of complexity. So we how can I say this? In that trend line that I show in one of my presentations, where you start the analytics complexity from the most basic up to the stochastic optimization or whatever guys you do. We're trying to do to create those templates even for the most basic descriptive epidemiological analysis, let alone operational research. So we are in that process of creating those templates as we speak. But as I said before, the data might not be there to support any of these analyses. It might be so full of holes. The timeliness of the data is not there sometimes as well, because of all these organizational challenges to inform these things. But certainly any, or any off-the-shelf templates that we can create and we can disseminate, that will be extremely valuable to increase the chances of having these techniques applied during outbreaks. Absolutely.
Thanks for your excellent presentation. Very interesting.
Thanks, Prof. Dick. I think with this, we can conclude. Thank you so much again, Victor, for making time for this and for sharing these amazing experiments you have done, but also giving us some food for thought to think about on templatizing and in understanding data gaps and how we can maybe strengthen more the open source data systems also in a way that can support these kind of pandemics in a timely manner. So we are not very reactive, but also prepared better for this in the long run.
If I may, Prabhati, and actually addressing the question from Dick as well, it's also the language you use. So for example, R is a very common language in epidemiological circles, but most people don't actually do R these days. If you now come up with Python or something else, as I said, most of the colleagues will jump out of the window. So how do we make sure that we translate all these complexities of the language, the programming languages they might be using, into some easy interfaces for them to act and work?
Yeah, definitely. So it is actually translation, not just in terms of technology and language, but also in the way that we communicate, right? We all have our own languages. So researchers have their way of working and speaking. So I think a collaborative approach to solve these problems is something that we definitely need to think more. And I hope this session have given some more inspiring thoughts for our audience. And thanks again, Victor. And thanks also, Martha, for organizing and setting everything in place so that we could do this very smoothly. And to the audience, please do keep in touch with us. If you have more ideas, you can always reach out. And we are also in LinkedIn. We have the sessions also will go online in YouTube. So please stay connected with Analytics for a Better World. And we'll see you again as part of the Café next month. Thank you so much. Have a nice day, all of you. Bye.
Thank you, everyone. Bye-bye.
Bye-bye.